In the acute diarrhea lecture, we learned that acute diarrhea was any diarrhea that had a duration of less than 2 weeks and was probably infectious, whereas chronic diarrhea was any diarrhea with a duration greater than 4 weeks. In between was the subacute, where it could go either way. Greater than 4 weeks for chronic diarrhea usually means not infectious. It's a medical disease. What I want to do is give you a framework for the different types of chronic diarrheas that there are, then go over a few diseases in this lecture that are secretory, and finish this discussion in the malabsorption lecture that follows. Let's start off with the different types of chronic diarrhea. They are secretory, osmotic, and inflammatory. Now, some people will say there's a fourth, and that is called malabsorption. In my mind, it fits that osmotic is malabsorption. I'll explain why. Specifically, malabsorption is a subset of osmotic. We'll see how that plays out as I show you this table. I want you to think of the three types of diarrhea along with certain characteristics that will help define them. That is going to be the osmolar gap, fecal whites, reds, and mucus in the stool. What happens with NPO? Is there a change? And what happens at night? Are there nocturnal symptoms? And finally, what is the fecal fat? In secretory diarrhea, the absorptive gut is turned into a secretory one, much like the enterotoxic organisms, only this is a medical disease that stays around all the time. Secretory diseases are going to secrete a lot of water into the lumen. So stool will be voluminous, but there won't be a lot of stuff in it. It's mostly water. Therefore, the stool osmolar gap is normal. And there won't be any white red blood cells, or mucus. And because this has nothing to do with what you put in your mouth, it just happens to be that these things are turned on all the time, there won't be a change with NPO, and there are nocturnal symptoms. And because all it's doing is secreting water, there won't be any fecal fat. Osmotic diarrhea, on the other hand, is not so voluminous. It's caused by putting something into your mouth that cannot be absorbed. Well, in order to balance out the water, if there's stuff in the lumen, water has to leave the cells into the lumen, and that gives you the diarrhea. And so there's stuff there, so there's going to be an elevated osmolar gap. It's not inflammatory, so there's no whites, no reds, no mucus. There will be a change with NPO, because if you stop putting that thing in your mouth, you reduce the osmotic load, diarrhea stops. And there are changes, and there are no nocturnal symptoms, because effectively, when you sleep, you're not eating anything, so the osmotic load is gone. And here's where the fecal fat comes in, because osmotic diarrhea doesn't necessarily have to have fecal fat. But if you are malabsorptive, essentially, it means you cannot absorb fats. So osmotic diarrhea is a larger category, which includes malabsorption. Malabsorption has positive fecal fat, but both malabsorption and osmotic share all the other characteristics. Inflammatory diarrhea is easy to spot. It's going to be positive red blood cells, positive white blood cells with mucus. And you probably won't do these other studies because you just go straight to the colonoscopy. And I keep mentioning this stool osmolar gap. What is that? How do you do that? Well, the stool osmolar gap should be a measured osms minus the calculated osms. In all reality, you're just going to use the number 290 for measured. And calculated osms, you actually check the sodium and the potassium, and your osms are 2 times sodium plus potassium. And if that number is very high, then there isn't a lot of other stuff. So if the osmolar gap is less than 50, it is likely to be secretory. If that number that you've calculated is low, then the osmolar gap will be elevated because there's other stuff that's not accounted for in this equation, which means there's other stuff there. So an osmolar gap greater than 100 means osmotic. Okay, let's look at this another way. When someone comes in with chronic diarrhea, they've had diarrhea for greater than 4 weeks, you have to ask yourself, is it one of the usual suspects? And you are going to ask them or look at their medication history before you jump to stool studies. Think of things like laxative abuse, medications, and don't memorize the list of medications that cause diarrhea. It's not worth it. Lactose intolerance, C. diff infections, which can be chronic, and celiac sprue. More on celiac sprue in the malabsorption lecture. So look for people who are trying to lose weight, people who are on a lot of medications, the person who has foul flatulence when they eat dairy, but it goes away after they eat dairy. These things don't require any testing. You can get the answer right just by asking them a few questions. But if it's not those, then you're going to have to decide which of these tests to do. And as a shotgun approach, you can get them all, but generally the story is going to lead you down a certain path. Red blood cells, white blood cells, stool osms, fecal fat, and make them go NPO. And what you're trying to do is separate them into secretory inflammatory, and osmotic. Secretory is going to have no fecal fats, no fecal white blood cells, normal stool osms, no fecal fat, and no change with NPO. When you get here, you're going to have to do hormones. But because these are so rare, these hormone secreting tumors, you're probably going to end up doing an endoscopy with biopsy to rule out something else like celiac sprue, which is more common, and also getting a C. diff because it's easier and simpler to do this than to get a VIP level. We'll talk about secretory cancers in just a second. If it's inflammatory, they're going to go straight to a colonoscopy. And if ever you put a tube down someone, either orifice, take a biopsy. Even if it looks normal, you might be able to diagnose celiac sprue or microscopic colitis. You'll see more about the inflammatory causes of diarrhea in the inflammatory bowel disease lecture. And lastly, there's osmotic. This is often solved with a history and physical, but it will be definitively diagnosed with an endoscopy and biopsy or some disease-specific test. We'll talk more about some osmotic diarrheas in the malabsorption lecture that follows this one. I want to close this lecture with a brief discussion of 3 diseases you might see on the test, but you probably won't encounter in life. All right, first one is a VIPoma. The path is that it's a tumor that secretes VIP, and VIP tells the intestines to go. This is a chronic diarrhea. Diagnosed by getting a VIP level, and resection is the treatment. I blew through that because I want you to recognize that that's never going to be the answer, but there will be a distractor, VIP or a VIPoma on your test, so I want you to know about it. So when you see it, you're like, okay, that's not going to be the answer. VIPoma, we talked about the Zollinger-Ellison syndrome already in the peptic ulcer disease, and this is going to be a gastronoma. The patient's going to present because the gastronoma stimulates parietal cells to secrete acid, virulent and refractory peptic ulcer disease, as well as diarrhea. The diagnosis was complicated, so let's review it again. You start by getting a gastrin level. If the gastrin level is less than 250, you have ruled out the disease. If it's greater than 1600, you have ruled in the disease. In between, you aren't sure, so what you do is get a secretin stim test, which should increase the gastrin. If the gastrin is greater than 1600 or the stim test is positive, and you localize with a somatostatin receptor scintigraphy, an SRS. Treatment is resection, because while the gastrinoma itself is not malignant, the constant stimulation of a gastrin to the parietal cells can induce stomach cancer. And the one we haven't heard of yet in the GI lecture, but have in the pulmonary lectures, is carcinoid. Carcinoid is a tumor that secretes serotonin. And serotonin wreaks havoc on the heart valves. Carcinoid of the intestines does not do anything until it metastasizes to the liver. Any serotonin that the carcinoid produces from the intestines goes to the liver and is broken down. But if it metastasizes to the liver, it can secrete the carcinoid into the hepatic vein and into direct circulation, where it's broken down in the lung, which means that intestinal carcinoid can only expose the right side of the heart. The fibrosis. This was in direct comparison to the carcinoma of the lung, which begins in the lung and secretes serotonin into the pulmonary vein, causing left-sided fibrosis. Right-sided, cardiac fibrosis, valve problems, flushing, and diarrhea is carcinoid. And you don't know you have it until it's metastasized. This is a board favorite because the diagnosis is made with a 5-HIAA urine test. Person's presenting with heart problems, flushing, diarrhea, and you get a urine. That's why it's always on the test. 5-HIAA to diagnose, CT scan to stage, and the treatment is with resection. So we finished with 3 specific diseases that you can actually learn, but we began with an approach how you can ask questions to hopefully figure out at least the right category, if not the actual diagnosis, even before you start doing any testing. Most of the time, you don't need to do a lot of testing, but you may be asked to interpret the results of the testing once it's been done. That's chronic diarrhea.